This week on the BackTable podcast.
We're coming into a conundrum, just in general, right? Because we have this concept coming up. There's other modalities like cryoablation, IRE, or pulsed electric fields, may or may not be different than IRE. And then you have like radiation, external beam, whether it's photons, protons, or charged carbon ions. We have internal radiation, right? Like TER. All of these, to some degree, have their benefits and everything. How are we going to choose in the future? It's going to be a huge issue.
Yeah.
Because there's never going to be comparative trials for all of this stuff. It's just impossible.
I'm telling you, options. When you get more options, then things get harder to
It's hard
figure
enough
out.
to enroll patients in any trial with any local regional therapy, much less looking at which one would fit.
And so I'm a huge believer in the immunomodulation, as you talked about. And man, we are going to really have such a hard time trying to figure out which one's the best.
Yeah. Welcome to BackTable Tumor Board, your source for the latest on multidisciplinary cancer care. Hey guys, thanks for coming again. Another BackTable episode. This time we're going to talk about ablative modalities. I have some very esteemed interventional radiologists with us. To my right, Kevin Burns, who's in private practice here in Southern California. To his right, BackTable extraordinaire, Sabeen Dhand. To my left, Kirema Garcia-Reyes, Y90 guru out of Mount Sinai, New York. And then to her left, Zach Berman out of UCSD, another incredible interventional radiologist with vast knowledge and expertise. We get to discuss ablative modalities today. Before that, again, I got to do these intro questions. I think it's only fun. If you were a sandwich, what would you be called and what's in it?
I'll be called a Big Mac just because I think it's a cool name. So I'm Big Mac.
But isn't there a Big Mac already?
No, that's my sandwich.
It's like boring.
Yeah.
Lame. What about you, Kevin?
I think it'd be called the KB. That's my nickname. And it would have every meat on it with some maybe barbecue sauce.
I guess similar, I'd be the KGR, just because those are my initials, and a lot of people call me that. Probably you could choose your own protein, your own meat, but it would have to have avocado, tomato, and onions.
Oh man, that's a tough question. I want to say ZB, which is the opposite of the KB. No meat and lots of vegetables and avocado.
Well, see, since I built this question, I thought about how I would answer it. And mine would be called centrally thick because I got a big booty, and it would be loaded with pork carnitas.
Oh man,
a little toasted on the side. All right, so now we've gotten to this. Hopefully, lighten the mood up a little bit. I want to talk about ablative modalities, right? And when we talk about ablative modalities, right, it can span the spectrum in HCC. We can ablate large tumors, we can ablate small tumors, but let's talk about a tumor that might have many, many different options to how you would ablate it. So we're going to talk BCLC-A, preserved liver function, sub 3 centimeter tumor. What is your thought process behind how you would choose to ablate that? And Sabeen, can you lead off?
Sorry. Before we start, can we define what ablation is?
Yeah, go ahead. You want to do it?
No, I mean, I think I'd want all your guys' definition of what we think ablation is, because I think it's an evolving metric that has very different meanings, and depending on what modality you're treating, a lot of people say they're ablative and may or may not be. For me, ablation should be synonymous of you killing every single tumor cell. And so if we talk about ablation, I think complete pathologic necrosis should be our goal.
Yes, I would 100% agree with you on that.
I 100% agree. Complete pathologic necrosis, going in for the total kill.
Yeah, I mean, for me, I'm coming from a Northwestern trained background, so I'm, radioembolization, everything. Very rarely will we do microwave. We just really favor on the Y90 side for ablative techniques, especially sub 3 centimeters tumor, peripheral based. I mean, I'll go to Y90.
I think for me, a 2 centimeter tumor, it's really going to depend a lot on location and imaging characteristics. If it's a tumor that, segment 6 kind of like central in the segment, and I think I can get it with ablation. I still am doing ablations, at least to 2 centimeters. But if there's any, and I will say, if there's anything I think is a little bit more complex than straightforward for patients to treat the tumor, peripheral lesions high up in the dome, I tend to pretty quickly, and they're enhancing, I tend to pretty quickly move towards radiation segmentectomy.
Yeah, I would say we're not doing much microwave. I say we're kind of Y90 first in that sense. Obviously, we can talk about histotripsy a little bit later. That's new onto the scene. So I think that's going to fall into the same kind of criteria as you would choose for a microwave. If something is 3 centimeters in the dome, I'm going to be treating that with Y90, especially if it's kind of a difficult location to get to. But like if something's central in the liver, maybe not a good candidate for a radiation segmentectomy. I think microwave or histotripsy, especially if it's a certain size, is an appropriate treatment.
Yeah, so I think we start with BCLC, is at least how I think about it, right? And we all can talk about the deviations from how we treat on BCLC as we keep going. The reason why BCLC recommends surgical resection or percutaneous ablation is that there's the most phase 3 evidence for percutaneous ablation, right? So we have a lot of stuff in the HCC space, but even more recently, with the collision trial looking at colorectal cancer, percutaneous ablation is equivalent to surgical resection from survival and local, progression. And so that's always a good place to start your thinking, is that we have level 1 evidence for percutaneous ablation. Now, I also believe very strongly, as you do, if you can't do an effective percutaneous ablation, don't push it, right? I'm not dropping lungs. I'm not, doing crazy amounts of hydrodissection. I'm not, if I have any doubts in my mind, we have good evidence for radioembolization for complete pathologic necrosis, but we do have to understand, though, we don't have the level 1 evidence like we do for percutaneous ablation, which has been tried and true over many decades.
When you talk about evidence, I also think it's important to talk about on the BCLC-A side of things. While there is phase 3 data, none of those are randomized control trial data. There's no comparative trial, one versus the other. And I love it. Riyadh was talking about this when he was advocating Y90 probably belongs a little bit higher than it is. None of the stuff that on the BCLC-A side, there's no RCT stuff on that side. That is on the BCLC, B and C side, but not on the A side. I also look at, I think sometimes, I follow y'all's strategy as well. I follow the guidelines. If I can ablate it, I'm going to ablate it. But if I have any question about whether or not it's going to be an efficacious ablation, I will deviate. My deviation is to Y90. And we do a fair amount of Y90. The challenge that I have with Y90, and we might jump into this pretty quickly, is that Y90 is a 2-part procedure, right? There's a mapping followed by a treatment. And so I sometimes think that, man, you got to bring this patient back twice. It might have been easier just to do this ablation, even though I had to put the patient through general anesthesia. What are your thoughts on that? Zach, do you have an opinion?
Many.
I knew you would. That's why I went this way.
So we ran into that same problem, right? And we also look at my encatchment territory here in San Diego. I cover all the way even to Western Arizona. And so asking a patient to come for a procedure is a 2.5, 3 hour drive for them. Then they have to do that 2.5, 3 hour drive back home same day, right? Because we do all this stuff same day. And then to ask them to do it again the week later is a big ask, right? And so for those types of patients, we've started doing single session radioembolizations. We've published on it our experience where they come in, you do the mapping procedure at the same time. And as soon as you figure out which artery is going to the tumor, you have a dose ready to go and you infuse the dose from there.
So your mapping procedure is not really a mapping procedure. I want to make sure that people that hear this, we can clarify this. You have a dose pre-ordered and you know exactly what you're going with.
Correct. So there's a few ways you can do it, right? So there's this concept of same-day Y90. And the same-day Y90, as published before, was the patient would come to the angio suite, you would do a whole mapping procedure, inject technetium, they would go down to nuke med, come back up after nuke med, and then do the infusion of the dose. That seemed a little excessive to us, especially since lung shunts very infrequently for small HCCs an issue. So instead of being same day, it's same session. So we've pre-ordered doses. If you're using glass, you have to pre-order it. If you're using resin, you can just be ready to go. As soon as you have your perfused volume, your nuke med can just say, I need 0.5 GPQs or 0.8 GPQs or whatever. They can draw it up and then bring it up to the suite. So the concept is they never actually leave the angiography suite. They come in, you still have to map. You still have to figure out which arteries are going to the tumor, but they're no longer going to nuke med for a lung shunt calculation, for instance.
Okay. So if they're not going to nuke med for a lung shunt calculation, what do you estimate? And I realize that this is a guess, but what do you estimate your lung shunt is? And then, what kind of activity are you ordering?
So all of this started, at least conceptually in my mind, based on a paper done out of Northwestern where they looked at many thousands of patients that were treated with Y90. And they stratified it based on tumor size, whether the patient had a TIPS, et cetera. And they showed that for patients with in Milan criteria, UNOS T1, T2 disease, the lung shunt is quite low. and they gave you an estimation, I think in theirs was 2 or 3% or something like that. I bump it up. I double it. I say it's 5% because, that's about what I was seeing in clinical practice. But more importantly, the worst thing that can happen is if we have radiation pneumonitis from this, right? Because that's our biggest fear is that we're going to be putting too much radiation in there. And you'll see with radiation segmentectomy, assuming a 5% lung shunt, even if 100% of the dose went to the lungs, you're still going to be below 30 gray.
Correct.
Right?
I was going to make sure you said that.
Yep.
Yes.
And so you're almost always going to be below that. So that's the first safety point, right? So I assume 5% because that's going to make sure I'm well below. And in our study, in our paper, I think the highest lung dose we got to was 9 gray. And again, we didn't know a priori. And this is 9 gray lung dose calculated on an actual SPECT CT, which is how we ended up having to do it for that study. As far as ordering the dose, I order, if I'm using glass microspheres, I'll do it to the Cunard segment of 400 gray or higher. Ordering an extra dose just in case if there's 2 arteries, both being 400 gray, I can put them both in there. If you're using resin, it can be a little bit easier because you can just draw up the dose right there in your nuke med department as soon as you know what your perfused volume is.
Okay. And now I assume that you're doing this for relatively small tumors, like you're not doing this for 5-6 centimeter tumors.
Right now, we use Milan criteria, as long as they're within Milan criteria.
Have you fell into any surprises?
Yeah. So the biggest issues we've had, and we've learned since then, the first one was almost arterial conduit, right? And so these are patients who would have never been candidates for Y90 to begin with, that you would have discovered that during the mapping procedure and maybe not have gone to the Y90. So for our first patient, had an MRI done at an outside hospital, had really, really severe celiac occlusion, and we just could not navigate through the SMA to get there. Not a great candidate for Y90. The second patient had a previous radioembolization at an outside institution where they dissected the right hepatic artery.
Okay.
Didn't know that. So when we came to do our single session Y90, there was no right hepatic artery. Couldn't do it.
So pretty much these were all anatomical. It was not about the tumor itself, but being able to get the dose to the tumor.
Correct. Yeah. And so we have now added as a requirement for good baseline imaging. Now, I'm not getting CTAs on everyone just to make sure these arteries are open beforehand. I think that's a little bit overkill. If you have a really high quality MRI that was done recently, you're usually pretty good.
I guess you talked about this too. So you order 2 doses, right? Let's say they have 3 feeders, and let's say you only treat 2 of the feeders. Mm-hmm. So what's your thought process behind that? I know what your thought process is, but I'm asking you so that you can tell everybody else.
Yeah, totally. So they come in for an angiographic procedure. For patients who are within UNOS criteria, it's almost never 3 feeders, right? You're talking 3 feeders, you're talking about big tumors, right? And those people should still get mapped, in my opinion. So what happens if there's 2 arteries and 3 arteries and you have 2 doses available? Well, they have to come back for a second procedure, right? And in the end, they're going to end up with 2 angiographic procedures, which is exactly the same that they were going to have if we had done a mapping procedure.
Exactly.
At baseline.
Okay.
You never add bland embo or something for that third?
My philosophy is if you've chosen radioembolization, it's because you believe it's a better therapy than bland embolization. And so, no, I wouldn't.
I mean, I think it makes a lot of sense, right?
Yeah,
so,
absolutely.
We know from experience and the data that Zach was talking about that really the lung shunt in these small, earlier tumors, it's really pretty much negligible, 5%, 6% at most. So, and the way we really haven't quite adopted this yet, but I think this is the way we're going to go just for efficiency. But we do it in, for instance, patients, we have had Y90 in the past, they have a new lesion, another segment, then we're like, let's just do same day, which is pretty much the same thought.
Single session.
Single session, sorry. Yeah, single session, not same day, different. And then we also do it, for instance, I have a patient who doesn't show up for their radioembolization. Mm-hmm. I have that dose, I'm mapping another patient that day, so then I'll do it single session. I started doing it same day, so give them the technician, send them, and then we realized there's a way to even, room time is precious. So I do think it makes a lot of sense.
Yeah, I do too. And Kirema, you probably can talk to this too. When you're treating a lot of patients and you have limited time, if you're going to add that mapping in, there's going to be a lag between your mapping and your delivery, right? Like, I think in a perfect world, we're doing it 2 to 3 weeks later. But in a real world, if you're treating a high volume patients and people have to take, you're going to take vacation from time to time, there's going to be a lag between when you map a patient to when you treat them. So if you can find ways to limit those opportunities, you might be able to treat patients faster.
And to be honest, I would say most times when I'm doing a radiation segmentectomy, I'm not injecting the technetium into the vessel I'm going to be treating.
True.
Right? Because I know there's no lung shunt and I don't want any chance at, any embolization, or I have seen it uncommonly. So in reality, I'm not really using that information for my radiation segmentectomy.
Is there any like insurance issues with that? The coding and stuff? Do you have to have the mapping before or no?
In my experience, when insurance approves you for Y90, insurance approves you for both the mapping and the delivery. You don't have to resubmit. And so we have not had any issues and we do this for international patients. I'm now, after talking to you, I probably will do this a lot more frequently, but we always did it for international patients. But we've never had any issues with insurance, even patients that, obviously the international patients, the insurance thing is going to be entirely different. But for patients that are traveling from further out, we've had no issues with
If you look at the codes, right, the codes are for the mapping procedure, angiography, ultrasound-guided access to the femoral radial artery, moderate sedation, a cone beam CT, right? You don't get to bill those again when you come do the radioembolization, right? Because you can't rebill for the angiographic portion twice. And so the only thing you're really adding on the second procedure is the embolization and, brachytherapy codes and stuff like that. So, even from a hospital perspective, you're not losing that much money, or if any money at all, because you're still billing the same codes that you would.
Do you think your procedure takes any more time?
So we actually measured that in the study. Our average time was an hour and 20 minutes. And so an hour and 20 minutes for a radioembolization is super easy. And most of that is bringing the patient in the room, getting the patient prepped, nuke med clearing the room, like a lot of that stuff, right?
It's awesome. Your catheter's already there. You mapped it, you're there.
Yeah, I think I've actually done some same days on repeat patients where I mapped them like a year ago and they have a new lesion. And I usually just bring them back in for treatment because I just use the old lung shunt and just dose based on a new CT.
So single session. I know I keep harping on
single
this, but
session,
same day is really the patient going down to nuke med, then coming back up. And my administrators would kill me if I did a high volume of that because it really ties up room time.
But single session makes a lot of sense. I really like that.
And I think when you do these enough, you start looking at imaging and kind of really getting a good sense, with obviously exceptions for everything of, this will probably, I'm in a watershed territory, or, I'm in a slam dunk. This is going to probably be just a single feeder to this small tumor. So
I would assume if the tumor is bigger than 3 centimeters, more often than not, Y90 is your treatment of choice.
Absolutely.
Is it the same? You would say
100% Y90.
Academic private practice, same kind of thing. Are there any barriers in private practice to maybe doing, is there anesthesia considerations in private practice? Is that a big deal?
I would say the biggest barrier in private practice would be, and this is not so much for HCC, but insurance approvals. And for HCC, they're pretty good about that. That's been not so much of a hindrance. But once we start going outside of HCC, I run into a lot of problems. And I would assume that at academic centers, you might be more, easy to go and do those procedures. But at the community level, you get slapped.
Yeah, I would say insurance, again, I generally never use anesthesia for these cases. Maybe, I don't know if we can talk about that. I generally just do moderate sedation. Most people are pretty awake during the mapping, so I can get them to hold their breaths, and then usually they can sedate them after that. So at least in our private practice, we can pretty much get anesthesia whenever we want. It's usually not a concern because they're a service industry, so they're trying to service us. But I would say insurance. We generally use the company's insurance portals, and so the 2 vendors will get insurance authorization for you. That's how we do it. That's the easiest way. You just submit all the paperwork to them, and they have somebody behind the scenes that does it. But it still takes 2 weeks to get insurance authorization. So at least at our hospital, they don't want to schedule until they have insurance authorization because they don't want to waste the spot. So there's a lot of delay when you see a patient to get scheduled.
Okay.
And then one more thing, the hospital charging is it's very variable, and the people who are charging for the case, they could miss a lot of things that makes the hospital think that this case might not be profitable, or it might be losing money for the hospital. And so those are some challenges that we face too. But that I'm sure comes up anywhere.
So when you talk, before we talk some of these other things, I want to hit cryo. Would you ever consider cryo in the liver? Do you guys do any cryo in the liver?
I don't.
I have.
Yeah, I have too. So the kind of classic example is a very peripheral lesion right next to a rib where there's a intercostal nerve sitting right there. And, if you have to hit the nerve, I've had some patients have issues with microwave ablation afterwards. So I've used cryo for those indications as well. Mostly metastatic disease. We do have a clinical trial open right now where we've been doing it with combination immunotherapy in patients with cirrhosis. Now, the issue is cryoshock is what most people are worried about.
Cryoshock.
And if you look at a lot of the early data, a lot of it was surgical, where they were doing huge multi-probe, gigantic ice ball ablations. Usually I'm not doing a cryoablation for a 4 centimeter tumor. It's usually like a 1 centimeter tumor in a really difficult location. Again, if you need a bigger ablation, either think about microwave ablation or radioembolization.
Yeah, I would say the same. Mostly metastatic disease. Maybe they're having pain. It's on the capsule. I treated one that was more central, and there's a lot of bowel in the way, and I wanted to see my ablation zone because I feel like with microwave, you can predict it, but you don't know exactly where it's going to go. So at least I could see where the ice ball was and make sure it wasn't touching bowel during the procedure.
I came across a recent article in JVIR where they talked about cryoablation adjacent to bowel, and they actually showed that even if the bowel was involved with the ice ball, that the bowel actually did really, really well. I wish I could quote this off.
It did okay.
It did okay. Well, it didn't.
Yeah.
There was no abscesses, or they didn't hit it hard. Was it your paper?
No, it was I think Shamar Young wrote it.
Yeah. It was, but it's very interesting.
I wouldn't try to do that.
No, I wouldn't advocate for anyone trying to do it. Thank you for saying that. But it was interesting to say. All right, so microwave ablation has been around for a very long time, right? It basically replaced radiofrequency ablation. I don't know many people that are still doing radiofrequency ablation in the liver. Microwave's just much faster. And then, new to the scene was, at that time, 2 decades ago, was Y90. And I feel like Y90 had to fight its way all the way through, basically almost 20 years worth of fighting to get to the point to where it is in terms of ablation. Cryo is still there. SBRT, we have opinions on. I don't necessarily want to go down that rabbit hole today. But what I do want to talk about is histotripsy, because histotripsy, we heard about maybe in the last year and a half. And Kevin, I know that you do a lot of histotripsy. Can you explain to me, how you started, or how does histotripsy work first? What does it do, and then how you started using it?
It's a lot of good questions. So histotripsy, I think the main thing from all the other things is it's non-invasive. So that's one thing that differentiates it. Patients are asleep for these procedures, generally under general anesthesia, although that's not a requirement, but it's not sterile. So we do it in an operating room just because we do, but it doesn't have to be done in an OR. Patients are basically prepped with castor oil. You rub it on to make sure you have good contact with this big water bath. I mean, if you haven't seen this, you should look up a picture of what this actually looks like. It's more difficult to describe, but you basically put 40 pounds of water on top of the patient in this water bath, and then this big treatment head sits in there. So it gets rid of any air from the treatment head all the way down to the tumor. And so you can get really good acoustic cavitation, which is how this works. So it's ultrasound. Think about like a small satellite dish, and there's an ultrasound probe in the middle. So you can see live what's happening, which is nice too. So you can see the acoustic cavitation going through the tumor, but it uses very high amplitude, short pulses. So it's a low duty cycle. So there's a differentiation between HIFU, which is high intensity focused ultrasound, which is thermal. So that's still a thermal. So that uses thermal properties of ultrasound where it's pretty much always on, and it tries to heat up the tissue. So that would be similar to microwave. But this is purely mechanical disruption. And so basically most of the time the treatment is not on. It's really super high pulses that turn off, and they create very high pressure, and it rapidly expands and contracts all the endogenous gas that's in every cell to basically mechanically ablate the tissue. So it's a mechanical ablation versus a thermal ablation, and that has a lot of advantages and potentially some disadvantages as well. But one of the main advantages is we're treating next to critical structures, or we're treating very central. So we can treat tumors that are in the hilum of the liver and potentially avoid a bile duct injury, a venous injury, a hepatic arterial injury. We have cases where we treat, if you do a thermal ablation right on the portal vein, you could have a recurrence if there's a heat sink there, but we don't really worry about that here. You can pretty much treat through the vein structure, and that whole tissue can be mechanically ablated. We have, follow-up CTs, and you'll see the vein is patent going right through the tumor cavity. So it can open up ablation as an option to tumors where you maybe thought wasn't a good candidate for microwave ablation.
I guess to follow up on that, so it is strong enough to destroy tumor tissue, but not strong enough to destroy vascular tissue. Why?
So it'll destroy any soft tissue. I think you could change the technology to make it destroy anything, but currently it's designed to destroy soft tissue. It will, so any cell that's present in the vein, artery, duct will get completely destroyed, but any sort of structure behind will not be destroyed. So the structure of the bile duct will stay intact, and same with the vein. So you'll see, a hepatic artery flowing right through a treatment cavity immediately after the procedure.
So like the endothelium and stuff like that,
that's
doesn't get zapped?
I think that's all going to be destroyed. But anything that is like collagen, think about, is not, it does not get destroyed with this. But it's a size thing. So if you have a vessel 2 millimeters or a duct 2 millimeters or below, those are going to get destroyed. Anything larger, which means that you can treat central. So maybe you wouldn't want to stick a microwave probe in a hilar tumor. Now you can actually ablate the hilar tumor, which maybe it's not a good Y90 because it's going to have feeders from all over the liver. So it kind of opens up some options for these more difficult tumors.
So why did you start using it?
I'm an early adopter of everything. So
you have a Cybertruck. I understand. My kids are obsessed with it.
I had heard about this, I don't know, a while ago. I was perfectly following them, and all of a sudden I got FDA approval, back in, I think, October of last year. So it's really been 1 year that this has been on clinical practice. When I went out, saw the technology work, I brought one of our surgeons went with us, which I think was pretty crucial in bringing this in. And then we basically went back to our hospital late last year and said, this is something new. I think we should jump on this. And then our hospital agreed. It's a major capital purchase, which is different than all of these other things. This is more like a robot for surgery price point. So that can be a sell depending on who's going to purchase this. Ours was purchased by our hospital foundation. It was a pretty easy sell to donors because of it's cool technology. Everyone's all about bringing cool technology to their hospital. And so that's what we got it in. So we were lucky enough to be able to have this pretty early, which, we've done a lot of cases now.
Yeah, I know you told me, I think you've done over 130 or something. So it's done with an ultrasound probe. It's non-invasive. Do you use CT for confirmation? Because my thoughts here are, what I personally like about microwave, what I personally like about Y90 is I know that I am either perfusing the tumor or I have my needle directly in. And I will say I am an incredible sonographer. I can see almost anything, but I don't always feel 100% confident that what I see is the tumor.
I'll agree with you. So I'll say that this procedure is a lot harder than it seems. So we all do liver biopsies. You can biopsy anything in the liver with ultrasound, really. But when you actually try to use the treatment head, you're not going to get those same angles you can get. So you're limited on patient positioning. So at the beginning, we were only treating subcostal. So think about that really limits you to left liver, maybe segment 5. And then now we're treating a lot of intercostal. So we are opening things up. Multiple centers have been able to treat segment 8, segment 7, caudate lobe now. So we're getting a little bit more creative, basically with patient positioning. But I agree, some of these tumors on ultrasound, now that we're treating a lot of metastatic disease, I found breast tumors are all isoechoic. And so that can be very hard to determine only on ultrasound. So we can use fusion imaging. So if the patient has a recent CT or MRI, you can load that in. The machine will do a fusion sweep and kind of fuse that to the existing image to at least give you some confirmation of where you are. But I still like to actually see it on ultrasound to make sure that things aren't off. We just piloted intraoperative cone beam CT. So we would, whatever position we're going to treat the patient in, we would do a spin CT with a mobile C-arm with contrast. That would get immediately loaded into the software. And so we were doing a fusion in the exact same position, which really helps with the fusion. So we actually just treated a tumor that we couldn't actually see with ultrasound. It was under the sternum. And because I was pretty confident that our fusion was accurate, we were able to deliver the energy in an area we couldn't even see with ultrasound. I probably wouldn't, and it's not a good candidate for really anything else. And so you can get creative. And I think as things advance, the CT is going to become much more important for this procedure, where every patient will probably get a CT. You're going to touch on the screen where the tumor is, and you're just going to say, I want this big of a size, and the robot arm is just going to drive right in. And you don't have to do all this manual movement of the machine right now.
So are you getting ultrasounds on your patients before treatment just to see if it's visible?
Yeah, I would say that's the most important thing if you're starting out, for sure. We have every patient come. We have a lot of patients traveling for this as well because it's new. So they'll come into town the day prior. We will ultrasound them, and we'll basically mark where the ultrasound probe is going to go, and then decide what position the patient is going to be in at that point. At the beginning, it's very important to do that. I would say now that you've done enough, you can usually tell based on their kind of body habitus in the CT whether or not you're going to see something. But I still do ultrasounds on everyone just to get a sense, because even if a patient had imaging a month ago and then they come in for this procedure, you'll be surprised, especially metastatic disease, how big these tumors can get very quickly. So you may be surprised. And that's just for, counseling the patient that, hey, now your tumor was 2 centimeters, now it's 6. And that may change.
How do you, where does it fit on your treatment algorithm now that we have, ablation, we talked tried and true, Y90, and now histotripsy, throw SBRT in the mix. Where are you making your decision in HCC?
I would say yes. We don't have evidence, obviously. This is a new procedure. I mean, there was a small study just showing that it was safe to be done. We are going to be enrolling patients in a registry, at least to follow these patients. I would say it doesn't really replace any Y90 for me. So, if you're thinking about bringing this into your practice, it actually has grown our practice. It hasn't taken away from any other procedures. So if you have an HCC that's 3 centimeters, I'm probably going to do Y90 to that. If you have an HCC that's 2 centimeters, especially in somebody who's maybe has a lot of varices, they're a lot sicker, I'd probably actually choose this because first, it's non-invasive. and patients may get a better or a result that's similar to microwave. Again, we don't have long-term data without putting a needle in the patient.
Yeah. I think the important thing is, you've hit on this too, is that we don't have long-term data, right? And I think this could be said about radiofrequency ablation. It can be said about microwave ablation early on when people were first starting to do it. There was no long-term data. At some point in time, all of these things that we once had no long-term data. But I think it seems to be that histotripsy has gotten a lot more adopted than Y90, which had to, I think, fight its way forward. And I could understand the different mentalities saying like, well, we're using an ablative approach that hasn't proven itself yet, but it needs time to prove itself, right? Like we just don't know. And I think as long as we are maintaining those conversations, with patients, and hey, this is an ablative approach, it's a non-needle approach, which is very unique, and I think it appeals. I think it's very attractive. But we need to make sure that people understand that we don't know what happens 5 years down the road, right? Like, might have incredibly resolved tumors. Patients might be dead. We don't know. And I don't think they're going to die. But we need to know what the durable data is, and we need to make sure that we proceed with what we think would be best approach for patients. But again, I think to a fair point to even early histotripsy adopters, at some point in time, everything started out without durable data. But that said, we have a lot of things with good durable data, and it's not a reason to necessarily not use something like that.
Yeah, I think a lot of why it's attractive to people, it's the fact that it's non-invasive. And I think, it's easier to try something that's not invasive than, I just think like everything, it's going to be, obviously we need data, and it's all going to be about patient selection, right? When you're talking to me about a hilar tumor that you're worried you might cause, that's hard to get to, Y90 would be difficult. I kind of get it. It's a little bit harder for me, honestly, to kind of think about these straightforward, radioembolization, radiation segmentectomy tumors, just because we do have a lot of better data. But I do think it's probably coming from the non-invasive part,
I agree.
The early adoption.
Well, so I was doing a Y90, and I wound up going through with this, but it was a cystic artery. It was the non-free wall of the gallbladder, and I was perfusing this tumor, and I was like, man, I was like, I'm running the risk of cholecystitis, right? An ablation, you could probably percolate it, I don't think I was going to get cholecystitis. I was going to deliver the dose just fine, but the volume was small, and I was like, I wonder if histotripsy would have made sense here, right? Like, I could have seen maybe utilizing it where I know that I'm going to, maybe my Y90 may not behave like I necessarily want it to, or I might be too ablative for, like, I don't want to perfuse the free wall of the gallbladder when I'm doing Y90. And so I thought about it there. And so I think there's opportunities to try to push it into your practice, even for probably the people that are a little hesitant to adopt it.
And I will say, and you said, and I honestly, I don't really practice it quite yet. So let's not underestimate that, anesthesia. If you require anesthesia, there are some risks to general anesthesia. So I think it's also important to think, we're thinking non-invasive, but if you really need to put the patient completely to sleep, there are real risks for that. There's sometimes I choose Y90 over ablation because I personally do ablations with general anesthesia, and this patient is a really high anesthesia risk patient. So
I'll say real fast, I'm still, if you have an HCC that's a radiation segmentectomy, that's still my go-to. I don't think that this replaces that. I think for the small HCCs where you're going to microwave them, that's where you can tease out whether this can be better. We didn't mention there is some potential for immunomodulation here, which we don't have. That's all the data is in animals now, where because this is not thermal, so it's not causing necrosis like microwave or radiation, that there are potentially some antigens that could be left around inside of this cavity that maybe in a patient who's cirrhotic and is probably going to get other HCCs, does this help somehow prevent the formation of new liver
that's
tumors?
Interesting. We're coming into a conundrum, just in general, right? Because we have this concept coming up. There's other modalities like cryoablation, IRE, or pulsed electric fields, may or may not be different than IRE. And then you have like radiation, external beam, whether it's photons, protons, or charged carbon ions. We have internal radiation, right? Like TER. All of these, to some degree, have their benefits and everything. How are we going to choose in the future? It's going to be a huge issue.
Yeah.
Because there's never going to be comparative trials for all of this stuff. It's just impossible.
I'm telling you, options. When you get more options, then
Yeah.
things get harder to.
It's hard
figure
enough
out.
to enroll patients in any trial with any local regional therapy, much less looking at which one would fit.
And so I'm a huge believer in the immunomodulation, as you talked about. And man, we are going to really have such a hard time trying to figure out which one's the best.
Yeah.
Or how do you even do the trial to do that? Or how do we do these trials to show that they work in that mechanism? It's going to be a huge problem we're going to be running into here soon.
If you're treating a lot of liver cancer, I would probably look into histotripsy because this doesn't have to be done by an interventional radiologist. So if you're at a big center, you may want to try to get your department into this before another department.
I agree. And I think that's
surgery, or there's radiation oncologists that are trying to get into this.
Yeah,
now.
I think that it's going to be more wide. I think what I see, I see less barriers, probably because I see more surgical oncologists willing to adopt it. And maybe that's why it's not as scrutinized as Y90 was, and whether that's good, bad, here or the other. But I see a lot less resistance outside of IR.
Sure.
But my questions here are, because I think people need to understand, and this is a good opportunity for people that might consider histotripsy. How do you do it? So it's mechanical disruption, but for mechanical disruption to work, tissue has to stay isolated, right? And so motion, especially in the liver, is not infrequent with breathing. So how do you overcome that? I want my naysaying to be satisfied, right? And I want other people to understand, and you're the expert, right? Like, so you tell us how to make this work. Like, so how do you overcome motion? What does the procedure time look like for certain types of ablations, like tumor size, right? As we talked about this in our session earlier, tumor volumes, as they grow exponentially by a factor of 8. So tumor size, and then how you make the liver not move.
I'll say time-wise, this procedure is probably going to take longer than a microwave that's a single needle. There's a lot of setup. Like, there may be an hour of setup before you're even involved in the case. Again, look at pictures of what this looks like. There's this big water bath that goes on. You have to position patients. They have to be completely shaved. There can't be any hair anywhere that could trap air. And so there's a lot of setup that goes into this. Ablation times. If you're doing a 2 centimeter volume without the need for cooling time, that could be 4 minutes. If you're doing a 4 centimeter tumor with no cooling time, that's probably 35 minutes of just touch the button and sit there. If you have to have cooling time, meaning it's close to the surface. So actually lesions that are deeper are faster to treat. The closer it is to the surface, there is a risk of thermal injury to the skin. And so maybe half the time of the ablation is just the machine just sitting there doing nothing. And so you could get a close tumor 4 centimeters and the ablation time is over an hour. So there's a lot of technical factors to consider. So if you want to do maybe a radiation segmentectomy for that tumor close is much better because the procedure is probably going to be faster, honestly. We do these all under general anesthesia. We just did our first case without it, but that was a unique situation. I would say in every case has been done in the world pretty much with general anesthesia. There's different techniques you can use. Some centers use jet ventilation in order to cause very minimal motion in the liver, but we don't have that available in private practice. That may not be as available in some centers. We are using dual lumen endotracheal tubes on every patient, similar to how they would do thoracic surgery. We're doing a lot of patients in the decubitus position, so left side is down or left side is partially down. And we will just collapse the right lung and then just ventilate the left lung. And that causes a lot of, basically makes the liver pretty still. Okay. You still have difficulties with doing the left side. When you pause the left lung, it doesn't work as well just because that's kind of in the middle. There's cardiac motion that can cause the liver to move. The ablation, you can pick every dimension. So you can pick the X, Y, and Z. So if you have a tumor and you can image it with the ultrasound. So you look at an ultrasound, you're in transverse, but you can rotate it in any plane. So you can see the tumor in every direction while it's moving. So say you had a 2 centimeter tumor, you could make a 4 centimeter craniocaudal dimension, where if maybe you only have 3 centimeters the other way. And so you can make sure that the tumor stays inside the volume as it's moving.
Okay. I think those are all good points. And I don't want to hit on histotripsy the whole time, but it was interesting to hear the dual lumen intubation to make the right hemidiaphragm not move as much.
Yeah, and so we can sometimes we'll put CPAP on it to push the liver down. So maybe you're doing a case subcostal and you want the liver to maybe stay down a little bit, we'll use that. Or if you want to completely collapse it, we'll just cause atelectasis, and that actually may allow you to see some segment 8 lesions that you couldn't see before because you can move the lung out of the way. You can have the treatment go a little bit through the lung, but you don't want it to go all the way through.
So which segment 8 lesion are you choosing that you wouldn't choose, for example, radiation segmentectomy for?
Well, I would say, so I would probably choose RadSeg for an HCC. We treat a lot of metastatic disease, so it's kind of overlapping there,
so
right?
You're talking about potentially a hypovascular tumor that you wouldn't see on your cone beam CT.
Yeah, we're definitely not treating anything in the dome. Those are still, I'm not going to get a margin there. So anything I don't think I'm going to get a margin, I'm not going to choose this.
All right. I want to talk about other ablative modalities. I don't want to just isolate on histotripsy. The Y90, Zach Kirema, incredible reputations in Y90. Walk me through your approach, how you do it, what you think. We talked about this briefly, treatment intent. But walk me through your basic ablative Y90 approach.
It obviously starts with preoperative, risk stratification and choosing the right patient, right? And so the more I've done this, the more I've relied on the ALBI score, more than just bilirubin alone. And I think that's for any local regional therapy. Because you can have a bilirubin of 0.3, but if your albumin's 2.6, you're just going to have a bad outcome, period. So I really like ALBI score. And I don't think the ALBI 1, 2, 3 numbers are particularly helpful for me. I like the number that you actually get. So if you have a number that's less than -2, I usually think that's a pretty good place to start.
I don't think most people realize that your ALBI score is actually negative.
Yeah.
Whenever you're doing
and the more
this.
negative, the better.
Yes.
If you have a positive ALBI score, you're in trouble.
Yeah, you're in trouble.
Yeah. So I like that. I really like the ALBI score for choosing the right patients for this. When you bring in for the procedure, either single session or staged mapping, it's the same way for me. They have good preoperative imaging, and I know, they have conventional hepatic arterial, a celiac anatomy at least. I'll start with a celiac run, and then I always like to do low bar cone beam CTs. I really start with a low bar cone beam CT. I find that to be very helpful. I think if you start getting selective too quickly, it can be quite difficult. And then from there, start selecting vessels and doing cone beam CTs until you find what you want to find. Cone beam CT is of critical importance. I think it's way more important than the angiographic pictures that you obtain. And I really harp on my trainees that you really need good cone beam CTs. If the patient's breathing throughout it, you have to repeat it. Not only is it for you seeing the tumor perfusion, but it's also critical for seeing non-tumor perfusion, right? If there's a right gastric artery going to the gastric antrum that you couldn't see, or a falciform artery or something, going somewhere where you didn't want it to see, you need a good cone beam CT. And then from there, you have volumes. And we talked about dosing in the dosing section, but if you're doing ablative dosing, in general, the hotter the better. And, going hot.
Do you have anything to add?
Very similar. I think, patient selection, key, as we all know. I think also treatment intent, right? When we're talking about these early stage BCLC, BCLCA, we are thinking a lot about curative intent, although we're doing a lot of bridging for these patients too. But so when I'm thinking, again, I think a key point, 2 key points that Zach made are, one, cone beam CT is standard of care. So if you're doing radioembolization, you should be doing cone beam CT. And second, I talk to my trainees about this all the time, is there is such a thing as being too selective. So start low bar, do your cone beam CT, and then from there I do use EmboGuide, so I use software to kind of try to identify the vessels. And once we get into those vessels, I confirm with cone beam CT. Again, remember that this 2D picture that you have angiographically is really not the same. And sometimes there's a little bit of the pie missing of that tumor, which you can only find if you're cone beam CTing. And then, if we're ablative dose in radiation segmentectomy, there is that these threshold doses that you want to hit. So at least 400 gray to the perfused volume. I tend to aim a little bit higher to like 600 gray if I'm using glass microspheres, just to make sure you get that complete pathologic necrosis.
So you do use software. Turns out you do use software. There we go.
Yep,
All right.
I
So
do.
here we go.
I'm not anti-software for dosimetry
I know.
either.
I'm picking with you.
But yes.
I want to re-emphasize this point. Y'all both said this, and I think this is critical, and we learn this a lot. And I think if you watch people struggle with Y90, you do low bar cone beam CTs, right? And what you're looking for with the low bar cone beam CT, obviously, is tumor perfusion, correct? And then when you're being more selective, you're trying to make sure that you have the same type of tumor coverage that you did with your low bar. Is that the general mindset that you have?
I think coverage and perfusion is also important, right? When I'm actually getting more selective, is the flow, it's all about flow, right? So is my flow actually going into the tumor? Because flow can change depending on where you're injecting from and how hard or what pressure you're injecting at. So I think it's really important once you get to the area where you're going to treat, that you actually try to simulate the microsphere flow to actually make sure it's going into the tumor.
I think that's an incredible point too. And we don't hear enough people talk about that, but this Y90 is a flow dependent process. And so making sure that you have the perfusion to the tumor the same way it needs to be to make sure that you deliver the dose you want, I think is critical.
Speaking about flow, like I've been getting a lot of information about different catheters that can change the flow to the tumor, whether we're using a sniper or other catheters, pressure-directed catheters. Any thoughts on that? Are you guys using it, changing your way of dosing or approach to the tumor?
So I think for this patient population, so where we're doing radiation segmentectomy, ablative dosing, I tend to not, again, I know so much from the actual cone beam CT, the mapping part, that I usually, for this intent, I don't feel it's necessary. Sometimes I will say I do use balloon occlusion for flow redistribution. So not to get more dose to the tumor, but to actually, if I want to protect, or if it's, sometimes these, again, not the same patient population, but you have this portal invasion cases where there's these tiny little wispy branches that are going to that portal vein tumor but getting into those branches is nearly impossible. So I do occlude past it, and then you can to redistribute the flow. But I personally think in small tumors, radiation segmentectomy, I pretty much get enough dose with a side hole and whole catheter.
So let me take this one real quick because I know how you're going to answer this. And so I will say that I'm probably going to be in a middle position for where Zach's going to land and where you land. I like to do very small volume segmentectomies, assuming I have tumor coverage, right? Mm-hmm. And you got to, I think, at the baseline tumor coverage. Now, these catheters in their current state probably cannot get as far out as I like to get for my subsegmentectomies. Again, I think in an ablative dose, and Kirema highlighted this in one of our earlier sessions, we want to limit the dose to the normal tissue, but we're maximizing the dose to the tumor. So from a strategic standpoint, I can't get my catheter where I want to be. I will say that I do use those catheters as an anti-reflux device, especially if I'm treating hypovascular tumors, a lot, big cholangios. Like if I really care about trying to make sure that I'm going to put a higher particle load into these hypovascular tumors, or maybe I'm dosing 600 gray for a left hepatic lobe cholangio, I'll put that catheter in just to make sure that because I'm blasting the hell out of this thing, I want to make sure that nothing's spilling anywhere close to the right gastric artery. I use it for that reason. But I want to hear how Zach, I know I have an idea how Zach's going to answer this question, but I'm interested to see what you want to say.
Totally. I'm going to quote you from earlier that I'm an early adopter, right? So if you look at some of the pictures that are produced by using these catheters that can flow redistribute, whether it be a balloon occlusion or a microvalve occlusion, clearly something is happening. And the pictures look strikingly different. If you ever do 2 cone beam CTs, 5 minutes apart, you can tell something completely different. In both with balloon occlusion and with microvalve, you can do it in animals. Clearly, there's flow redistribution. You're getting higher T to N ratios, et cetera. The problem we have right now is, does it actually translate to better clinical results? So we definitely have prettier pictures, that's for sure. But the question is, does that translate to better results? And I think in my experience, yes. But I'm not ready out there to say like this needs to be part of the guidelines and that everyone should be using these, adjunctive techniques and everything else like that. I think personally, where I feel more compelled to use it are larger tumors where you're going to have a lot of intratumoral homogeneity, right? 2 centimeter HCC.
Intratumoral heterogeneity.
Sorry. Yeah. Intratumoral heterogeneity. 2 centimeter HCC segment 8, there's no reason to use it, right? Now, that same segment 8 perfusion, now you have a 6 centimeter tumor. Maybe you do want a more homogeneous radiation field, and anything that can get you a more homogeneous radiation field may help. We need evidence, though. And that's a huge area that I think needs to be addressed, and it will be. But that's where I see the use of these catheters for.
And I will say I commend you. Like, I think you said that perfectly. I think, we're in a field, interventional radiology. It's based on technology. It's based on innovation. There's going to be a lot of new therapies, new devices on the market. And honestly, we bear a huge responsibility to really steward, the way we steward this new technology, the way we sell it to patients, the way we, gather data to actually make sure we're doing the right thing for patients. So I think, we all love talking about these, and we love using them because it's awesome to see more homogeneous distribution. But like you said, it's our responsibility to get the data and to really, figure out what really is best for the patients.
I think that's probably a great way to conclude this, right? We know that things are up and coming, and I think it's good for us to be on the front end, like you said. If we're not on the front end, we're going to be on the back end, right? And so we have to be leading the charge, but we have to be doing it following the right outcomes and making sure that the patient is receiving the best benefit for this. Anything else to add?
I think one thing about ablation, so we were talking about curative intent, going back to what you talked about, the immunostimulatory, there's a lot of stuff out there that's coming out cryoablation, IRE, Histotripsy are the big three that are investigating this. And I think in our future, this is coming. There's a lot of trials. The first one was a phase 2 trial with melanoma, looking at ablation and stimulating a response for patients who had already failed immunotherapy. 25% of patients responded. That's a huge amount to that, right? And so figuring out what type of ablative modality we need and when to do it and the sequencing is going to be a huge thing. And if we redo this in 5 years, I may have a very different discussion here.
Correct.
Exactly. All right, well, that was cool. Well, thank you guys.
Cool.
That was a blast. I think we went well.
Yeah, thank you. Thank you.
If you enjoyed this episode, go follow or subscribe to BackTable Tumor Board on Spotify, YouTube, or Apple, where you can watch or listen to the full season covering all things HCC. We brought together leading experts in oncology, interventional radiology, hepatology, and hepatocellular surgery for discussions that matter and to help you level up at your own HCC tumor board. You can keep waiting for each episode in the season to drop Fridays on the VI show, or you can go follow or subscribe to BackTable Tumor Board and get them all, including the full video discussions and tumor board case reviews on Spotify and YouTube. Enjoy.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.